Is that part of non-equity, or am I too rude? Maybe I'm too rude. But it is enormously important that we address it. We should address traditional quality, and you'll do that in the conference. But we should, more than anything else, focus on the functioning of a GP in a total healthcare system. And we should remember that we are healthcare providers in a democratic society. And if those who pay us, if they don't like us, they quit us. So in some way, we have to address the collaboration with the public and with public credibility. I think this slide is one of the most important ones when we should address future quality agenda. The next one is we should address a population approach. This is modern healthcare. You shouldn't just take care of those who come to your consultation. You should take care of those who are on your list or in your district. And in managed systems like the Danish system, which is a managed system, we have the problems with waits. They've had the same in UK. And in the market-oriented systems, you have the problem with costs, with lack of equity, with too much or too little access to technology, and lack of insurance. America, the United States of America, is a disastrous example on all the problems with a market-oriented system. But both systems has their inborn problems, which we should address in our quality work. We should, in other words, address how to ensure the front line, how to ensure the integration, and from a quality point of view, we should broaden our indicator agenda and our measurement agenda in such a way that we measure all the things I talk about here. And at the same time as we should do that, we should remember to be loyal. Loyal to society, which has a disastrous challenge in Europe in years to come, and which really will demand for creativity, will demand for collaboration if we should success in having a sustainable, well-functioning healthcare system. I'll just show you a couple of slides from the demographic challenge in Europe in years to come. It has been calculated, and of course it's calculations that could be changed because we hopefully react in some way. But it has been calculated that in Europe the growth will stop at the latest in 2020, which will mean lower tax incomes, which will mean lower willingness to pay to a healthcare system. Those in my age, we had 100,000 or 95,000 newborn people when I was born. When we were on the lowest, and those are those who go into the working market now, we had 50,000 newborn in 1970 to 80s. Now we are around 60,000 newborn. A tremendous lack of staff, and it is the same story in all European countries. And no generation have been so demanding like my generation. How to cope with that in a healthcare system? How to cope with a healthcare system where the number of people above 65 will raise with some 60 to 70%, where the number of people above 85 will raise with these figures, and where the total expenditure to healthcare, all other things equal, will raise like that. If we have success with chronic care, then these figures are false. Because if we have a successful chronic care, people will live in a high quality life until they reach their biological corner at the age of 95 or something like that, and have a terminal drop of 3 months' time without having any demand from healthcare in all their time, except for good chronic care. That is if we have success in chronic care. If we fail in chronic care, people begin to have all their disabilities from the age of 60, and they will live for another 30 years with a lot of demand from healthcare, social care, and so on. We really have to be creative if we should cope with this in future. We should cope with an increasing complexity in healthcare systems. A complexity that tends to widen the gap between what we know or even between science, what we produce of knowledge, and what I know and what I do. We should work much more with how to implement change, how to sustain change, how to make it all work, and that's where EQuiP have given me so much inspiration in all my time. So I really like that. So I think we have to accept that we should work with structured medicine, that is evidence-based medicine. We should accept guidelines where we should reach consensus on what we want to do and what we don't want to do. We should accept much more patient involvement to cope with all that. We should work much more precise with change management programs, chronic care models, care management programs, case management, and so on. But what is even the most important? That's culture. I'm currently sitting in a working group, how to develop future general practice. And in some ways, I'm bored in that working group because the working group, sorry Lisbeth, not that bored, but the working group has a tendency to look into general practice and what should general practice do. But what's the real challenge is to develop a healthcare system where all providers go for each other. To develop a system where they think as they do in Kaiser Permanente, a referral to secondary care is a failure because we as super specialists have been too bad in supporting the frontline care in doing the correct thing or too bad in preventive care. So in the working group on future general practice care, I keep saying that the real challenge is to make the hospital focus on general practice, not to discuss what general practice as such should change. They should change a lot also. But culture eats strategy for breakfast every day and structure for lunch at the same day. That's the fact. What are the culture we meet each other with when we should collaborate on future challenges? And if structure and culture work together, we can do tremendous good things. We can make a total healthcare system work so that we can keep primary care. I started with asking whether primary care is an old-fashioned concept. I don't think it is an old-fashioned concept. But primary care is both to work together on a vertical line with the super specialist and to work on the horizontal line with families and with the municipalities. And if we can create that balance, we are on our road to a high-quality general practice care. If we also can readdress the research agenda so that we make real clinical research about the clinical problems that we see in general practice, then we are on the track. And if we can continue to broaden our research agenda in such a way that we look whether organization type A is better than organization type B, whether we challenge different ways of organizing healthcare. If we can do that, those two types of research, and if we can follow up with funding, and I was so happy to see the head of the National Board of Health is here today. Welcome, good to see you here. And she was nothing. It shows a good future, at least for our country, that we have to address these problems if we will make our healthcare system work. 3 years ago, a group of general practitioners and healthcare planners met in a wonderful Italian city. Barbara Starfield was there, Edward Wagner was there, and we discussed for a few days what are the things we should work with in future if we will make a perfect healthcare system. We should focus on shared leadership. We should focus on interaction with the public, our democratic payment system, public trust. We should focus on population-oriented management. We should focus on integration, We should focus on culture in the professional networks. We should focus on creating an infrastructure that supports frontline care. We should focus on creating the best payment mix. Fee for service is a stupid way of paying. Capitation is a stupid way of paying. Quality may be the way of paying. We'll hear that in the next presentation, whether it is, but we should find some good mix. And we should measure and change and do research. Those were the 10 topics we said. If we address them, we have the chance of getting a good healthcare system in future. And the challenges are there. People want equity, accessibility, capacity, and they will have fulfilled their expectations, and they will see on paper that it is quality. That's the future imperative. This man, it was stated in the one I took, he wants more hair, less fat, and a better sex life, and he wants his health plan to pay for it. So looking into the next generation, and I think we have the obligation to look into the next generation. We have the obligation to deliver a healthcare system that are sustainable, that works well. We are dealing, as I hope I have shown, with very huge and serious challenges, as you can see in this young boy. But I'm also sure that we can make it if we work together. And that's what I think, I hope I have given inspiration to in this presentation. I know that a lot of you will think he's talking, and I'm always talking, and he's talking up in the helicopter in theory, let's get concrete stuff. And I completely agree with you. In theory, you know everything, and nothing works as expected. Therefore, you employ some people with abilities within organizational structures, and still nothing works as expected. But at the end of the day, you turn to this wonderful pragmatic place in general practice where the fact is that everything works, but nobody really knows why it works. I hope we can show a little more about why it works by meeting at conferences like this. And this was my quick glance into a very serious matter where I think we should broaden our quality agenda and where I think we should go for creating a sustainable, trustful healthcare system where general practice as a frontline only is part of that healthcare system. Thank you.